Okay, since it's so quiet, I think we'll go ahead and get started. Hello, my name is Kylie. And on behalf of the Mayo Clinic Comprehensive Cancer Center and the Center for Health Equity and Community Engagement Research, I want to wish you all the warmest of welcomes. I'm so glad you're able to join today. To those of you who are attending virtually and here in person, we're so glad you could make it. I am personally just so grateful and humbled to be working with friends and organizations who are working to address health disparities, barriers, and make sure health promotion gets to our immigrant communities. And speaking of those friends, I'd like to introduce Khadija Ali of Pamoja Women. She is going to be fostering the conversation today. She is delightful. She's a great woman for the job. So thank you for your assistance today and for the many months leading up to this event. We've had a planning committee kind of working on putting together these stories and these speakers for you. So thank you to all of those involved, specifically Pamoja Women, Together Against Breast Cancer, the Cambodian community of Rochester, the Center for Health Equity and Community Engagement Research, and lastly, 125 Live. They've hosted us many, many times and have opened their doors to the public, as well as opportunities for people to come here and make lifestyle changes and build camaraderie with other community members. And with that, again, welcome. Thank you for being here. And Khadija, you can take it away.
Hello, everyone. Thank you for being here. My name is Khadija Ali, and I have been working for the past couple of months with this lovely lady right here, and a lot of other amazing women that you'll be hearing from today. I run a nonprofit here in Rochester called Pamoja Women. It's a nonprofit that serves the East African women and youth girls here in Rochester, and we are basically a one-stop resource for the women and the youth kids. And we do a lot of things from like helping them with applications, either if it's financial literacy, health education, and just women's health overall. And we were so happy to come on board with Kylie when cancer conversation was brought up to us. It's something that we really need to talk about in our community. It's something that we feel we're always hiding it, and it's not something that we always talk about. And prevention is something that we really, really, really need to discuss. So today we will have a couple of speakers. We'll have time for a question at the end, and then we also have some people on virtual that they can also wait for the Q&A at the end. First, I would like to invite to the podium Dr. Shafi Mohammed. He is a physician in community internal medicine and supports clinical and community-based research projects that address health disparities for local immigrant communities here in Rochester. Dr. Shafi.
Thank you, Khadija. Hello, everyone, and welcome. Thank you for showing up. This is a very important topic that I hope that I can contribute to and that you can learn something new today. If not, a reminder for those who already are aware of this information. So I'm with Community Internal Medicine at Mayo Clinic. I work at the Baldwin building. I also spend time in the hospital, St. Mary's Hospital, 6 weeks out of the year, and take care of people that are sick, but I also focus a lot on prevention, and that's something that makes me interested in cancer screening because it's a topic that we discuss almost every single day with our patients. Let me get this clicker working. All right, thanks, Kylie. So the first slide is what is cancer? And cancer has a lot of different meanings to people, and that can mean that somebody first hears about cancer because either they got diagnosed with it or they know somebody who has cancer. And it could be a really scary experience if somebody got diagnosed with a cancer that is either untreatable or has treatments that are very difficult to tolerate. So that's their first impression of cancer. And then for others, it's a diagnosis that occurs because They underwent screening and it was kind of an early stage and it was treated fairly quickly. So then in their experience, cancer is not something that should be feared. It's something that can be treated or prevented. And so that's typically how most people experience cancer. And then others just hear about cancer either through people that they know or through these cancer prevention campaigns like breast cancer screening month. So just in a little bit more details, cancer is a disease in which somebody's body, that can grow in somebody's body. It could grow from any cell in the body and it can occur anywhere in the body. And for that reason, sometimes it's unpredictable where cancer will occur. But there are cancers that are more prevalent and they are more common in our community. And so for those cancers, fortunately, we've developed some screening methods to detect them early and then to treat them early after that. And cancer occurs because there are mistakes in cell replication. And that's when cells divide to make more of themselves. So on the surface, if you're just looking at your skin, if you get a cut, for example, the skin replaces itself after a period of time. You might get a scar, but cell replication happens, cells divide and new cells occur. There are cells in the body that do not undergo that fast replication, and those cells are permanent. But then there are mistakes that can occur in the DNA of those cells, then that leads to overgrowth of cells where there should not be. And so this can occur because of sporadic, or it could occur because it's something that's inherited. So some people might have genetic mutations that then lead to cancer development. When the cancer occurs in an area, one focal area, that's called a localized cancer or a tumor. But when it spreads from that one area, then it's called metastatic cancer. So this is just a slide showing what a normal skin cell looks like in different layers. And then when cancer cells occur on the skin, you'll see that it's a clump of cells that are growing out of control. And then if it's just on the surface, you can say that it's just localized, maybe a stage 1, but when it goes deeper into the surface of the skin, it might be stage 2. And then if it's going beyond that, going into your lymph nodes, might be stage 3. And then if it's going beyond that, then you're thinking that this is a stage 4 or metastatic cancer. So I mentioned a little bit about sporadic versus inherited mutations. And mutations are basically mistakes in the DNA of the cells that then lead to overgrowth of these cells that then become a tumor or a cancer. So this is a slide on risk factors for cancer. It could be internal or external. And internal things are things that already exist in your body. So you have a personal history of cancer or a family history of cancer, and then that puts you at a higher risk for developing cancers. For some reason, sometimes people have unidentified mutations and they're not the common ones that could be screened for with genetic testing. And so there's a lot of research in this area, and hopefully more of these mutations are determined, and then people can be screened for them in the future. So older age. So as people age, there is a higher chance of having these mutations and then having cancer, regardless of whether they have genetic risk factors or not. It's just over time with multiple cell replications, then there's a higher chance of mistakes occurring. And then chronic inflammation. This can happen also externally if somebody is constantly having elevated inflammatory markers, for example. We can check that on blood tests, but if somebody has an autoimmune condition, for example, or multiple chronic conditions and their body is constantly undergoing inflammation, their immune system is overactive, there's a higher chance that then a mistake can occur in all those cell divisions and then a cancer occurring. Hormones. So some people intrinsically have elevated levels of certain hormones, but then people also can take hormone replacement therapy, and then that introduces an imbalance in their metabolism, and then that causes cancers to occur potentially. Immunosuppression. So then some people just have a lower immune system because of conditions that lower their body's defense system, or immunosuppression could be due to medications that people take that then suppress their immune system because it's on overdrive, and then that decreases chances that mistakes will be corrected, and then that also can lead to a tumor forming. External factors. So obesity can also be internal, I would say, because there are some metabolic conditions that can cause somebody to have a slower metabolism of food that they intake. But then there's also obesity due to dietary reasons or due to lack of physical activity. And then that also can increase the risk. And I'll talk about that a little bit more. I'll talk about some of these components a little bit more in detail in slides that are coming up. Tobacco use. So this has been known for decades now. Cigarette smoke and tobacco in general has over 4,000, chemicals and poisons that every single puff gets introduced into your body, and not just only in the lungs, but also into the bloodstream, and causes a wide spread of problems, not just, cancer. We're talking about heart disease and strokes and things like that. So definitely encourage anybody that who smokes to smoke. Alcohol is also another well-known carcinogen, and it's unfortunately consumed almost on a daily basis, but it's something that research has shown that it is associated with a higher risk of malignancies. And not just liver malignancies, but just other cancers as well. Some types of viral infections can cause cancer. HPV is well known to be associated with cervical cancer. And then we have hepatitis B and C, which can cause liver cancer if untreated. And then exposure to radiation. This could be due to testing that people undergo, but also exposure from the environment, and that can damage the cells and then lead to a higher chance of cancers. Chemicals I'll talk about in upcoming slides, and then we just talked about hormone replacement therapy. So diet. I won't go into too many details here, but one of the dietary factors that's commonly associated with high risk of cancer is red meat, and colon cancer is one of the cancers that it can cause a higher risk for, but it also can cause just widespread inflammation in the body if consumed too frequently. So I'm not saying people should not eat red meat, just sparingly, a couple of times a week, 3 times a week, that's fine. But don't overdo it. Dietary fat, this is also potentially associated with cancers. Studies have been showing mixed results, but that's all I can say about it because there's no definitive answer for that. Dairy, uncertain risk, carbs, increased risk for cancers if consumed in high amounts. So really no clear guidance on these. Overall, just eating a balanced diet is the main thing, making sure that you're exercising, matching what you're taking in with what you're putting out with activity, and that can also help with weight loss or preventing obesity. Coffee may or may not. You always hear studies that show there's a reduced risk of cancers with coffee consumption, and then others that may say something else. So for now, we'll just say, according to what's available, that there's a potentially lower risk of cancers with coffee consumption. And then alcohol, multiple cancers have been associated with them. Exercise, this is mainly just to let people know that there's no clear type of exercise that's going to reduce the risk of cancer, but staying physically active can help to reduce the risk, and also can help to maintain a healthy weight. And in general, I recommend 30 minutes of exercise of any type every single day, schedule time, not just what you're doing on a daily basis, but a little bit of beyond that, so that you're getting your heart rate up, and that you're hopefully also matching what you're taking in the food. Obesity is a spectrum based on your height and weight, and that is calculated and results in a body mass index. A normal body mass index is 20 to 25, 25 plus to 29 is considered overweight, and then 30 plus is considered obesity. And multiple studies have shown that obesity is associated with the increased risk of cancer. And in 2014, a study showed that obesity was associated with 40% of malignancies. And whether that's a direct cause or whether it's association, I can't really say, but that's just for your information. And just to help people to always work on maintaining a healthy weight and follow the dietary and exercise recommendations that we just discussed earlier. Health effects of secondhand smoke. So I touched on this earlier, but you can see that there's a higher risk of lung cancer, stroke, heart disease, problems with reproduction, like low birth weight, for example. I'll just go on to the next one because this is just something that's well known and people shouldn't be smoking. And then in terms of specific chemicals, there are different environmental and occupational risks associated with certain chemicals. And they don't just cause an increased risk of cancer, like for example, your lung cancer, bladder cancer, and other cancers such as leukemias or blood cancers associated with exposure to environmental chemicals. This is a really busy slide. I don't want to go into too much. One of the lung cancer associated chemicals is asbestos. And you know that's you always see commercials that are talking about mesothelioma type of lung cancer. And that was one chemical that fortunately our people are more aware of, and it's not used as commonly in construction. And then you have chemicals such as what's used in agriculture. For example, Roundup has been one of those chemicals that's been associated with a lot of different malignancies. I'll go on to the next slide because there's more information about this. DDT was an insecticide used for malaria control. Now it's banned, but it is a known carcinogen. TCDD is another type of chemical that was in Agent Orange. So for those who were in Vietnam War and got exposed to Agent Orange, they're bound to have higher incidence of certain malignancies. Radiation exposure is in a spectrum. So there are low levels of radiation exposure. That's usually with everyday occurrence. We're all being exposed to a certain level of radiation, but not at toxic levels or lethal levels. And as you get up the spectrum, category 5 here is one where somebody might be exposed to acute radiation poisoning, such as, for example, a leak at a chemical plant or something like that. But major sources are usually from outer space, coming in from rays from the sun. Fortunately, we have some protective mechanisms in the atmosphere, but other things that can expose us to radiation include testing that some people might need to undergo, like X-rays, CT scans, PET scans, things like that. But we try our best to limit the use of these when doing diagnostic testing or treatment planning. Talk about toxicity just a little bit, but that depends on how much and for how long somebody's exposed to something. And so the longer the duration, the larger the amount, the higher risk of toxicity. Now, screening recommendations. I starred the cancers that we typically screen for. So the pink ribbon on the top left is breast cancer. We screen for melanomas, colon cancer, cervical cancer, lung cancer. There are other cancers there that we can screen for, like liver cancer, but I won't be talking about that in this presentation. So for skin cancer, this is one of the more common questions that comes up on almost every single day when somebody sees a spot on their skin and they're not sure if this is skin cancer or not. There are some well-known skin lesions or spots, moles, that are clearly benign, but then there are others that undergo changes, and you can follow this A, B, C, D, E criteria. So A being asymmetry, B being borders or irregular borders. C is if you see different colors, that might be a risk of cancer. D is diameter, so if it's getting larger than half a centimeter, but closer to a centimeter, then you know that that's something that is concerning. Now, there are benign skin spots like a seborrheic keratosis, like that one under the letter B, That's a very common one that can be large, can be in different stages, but in general, it's more oval or circular, and it has a raised, stuck-on appearance. That's usually a benign skin lesion. But if you're ever concerned about any changes, then that's something that you can talk to your doctor about. And then E is evolution. So if you see a spot on your skin that's changing, then you know that that's one that you need to have looked at. Lung cancer screening is indicated for people above age 55 and above, so age 55 to 80. And if you have any history of smoking for at least 15 years, one pack per day, or if you've quit within the past 15 years and you've had that many years of smoking, or if you smoked 2 packs a day and it's 15 years, then you just have to do that calculation. Talk with your healthcare team when you go to your appointments. This is a CT scan of a spot on a lung. This is on the left lung. The images are inverted when you're looking at a CT scan, but it's the top left lung. You see that spot that doesn't look like anything else in the scan. And that's a tumor in the left upper lung that's really concerning for a cancer. Breast cancer screening, so recommended for ages 40 to 75 in general, but it's done every 1 to 2 years. At Mayo, we do the screenings every year, and that's supported by some studies that show that maybe one screening every year is better than screening every couple of years. But there are different guidelines. But the United States Preventive Services Task Force recommends every 2 years. And so there's a little bit of a variation if you have it once or every 2 years. This is a picture of a mammogram. So on the left side, you'll see a normal mammogram. On the right side, there's a nodule, and that nodule is concerning for a cancer. This might be detected before it's even seen on a mammogram, but a lot of times, for example, this one is a little bit deeper into the skin, so it might be difficult for anybody to notice anything on the surface. But if this is found without showing any symptoms, then potentially it can be removed. And that's the good thing about screening, because you're finding things before either they're out of control or before you even notice it. Colon cancer screening. Now, this slide's a little bit dated, because now the recommendation is to start screening at age 45, and that's for everyone. And for people who have a higher risk of cancers, the recommendation is to screen 10 years earlier. Same with breast cancer screening and other cancers. If there's a family history or a genetic risk factor, then you should definitely screen earlier. Modes for screening are either with colonoscopy or different types of stool tests. There's endoscopy, there's a sigmoidoscopy, that's kind of a half colonoscopy, and then there's a CT colonography. But the method of doing the screening should be discussed with the healthcare provider. For people who have a higher risk or have a history of polyps or a family history of colon cancer, they should do a colonoscopy to make sure there's direct visualization of the colon and removal of anything that could predispose them to having a cancer. But for average risk folks, you can do a Cologuard test, you can do another stool test, and the screening interval is different between the different testing modalities. This is a slide showing what normal anatomy looks like on the left, and then in the middle you'll see that there's a picture showing polyps. These are little outgrowths from the wall of the colon that could become cancer if left alone. And then on the right side, you'll see the different stages of colon cancer. So if it's localized, that's stage 1. If it's deeper into the wall of the intestine, that's stage 2. Even deeper into the kind of muscular layer, then that's stage 3. Stage 4 is when it goes into distant sites. Cervical cancer screening starts at age 21. And that's one where there's association with HPV virus. And so there's a vaccination for preventing HPV in earlier years. But for adults starting at age 21, Pap smear is recommended every 3 years. HPV testing is not recommended until age 30. And if somebody has both the HPV test and a pap smear at age 30, then the screening interval changes from every 3 years to every 5 years, as long as the testing is normal, and that continues until age 65. So in conclusion, we have some just recommendations. Maintaining a healthy weight, eating a diet that's well balanced, rich in fruits and vegetables, avoid red meat as much as possible. A few times a week is not a problem. Portion control is really more important than the types of food that you're eating. Limit alcohol or abstain from alcohol intake. And in 2020, American Cancer Society recommended against drinking alcohol. Avoid tobacco in any form, smokeless smoking, avoid vaping, hookah smoking, all of that. Anything that shouldn't be in your body, just avoid it at all costs. I'm not trying to, just say that. I really mean it. It's not, you're not doing anything for yourself. Even if it's altering your mind, if you're feeling good about doing any substance, just don't do it, because in the long run, it's not going to be healthy for you. It's not going to be healthy for anybody around you or greater society. Avoid excessive tanning. If you're going to go out into the sun, put on sunscreen. Make sure you do that all the time, regardless of your skin color. That's something that there's some misconceptions about, and people should always try to protect themselves. And if you're not putting on sunscreen, wear clothing that's loose fitting and protecting you against the radiation from the sun. Vaccinations for HPV for younger boys and girls, and then getting recommended to cancer screenings. Thank you.
Thank you so much, Dr. Shafi. That was a lot of information in just short time. But this is something that we need to discuss and need to talk about. And when he was going through those slides, and I'm like, oh my God, yes, that. Because a lot of the time, I think that we see in our community, in the African community, is when we go out in the sun, we're like, oh, it's okay, our body melanin. The sun does not get to us, but no, we still need to have that sunscreen on. And just telling the women that is, no, what are you talking about? We live in East Africa. The sun is right here, and we've survived. But like, no, we're in a different country now, and things are different. We're noticing more. We're finding out that cancer does exist anywhere in the world. That we also get it, and this is something that is really dear to us, that we are starting this conversation about that, because we usually notice having cancer like on our late stages, when it's really time to go to the doctor, because we did not want to do it at the beginning, because whether it's religious beliefs, whether it's cultural beliefs, we're like, it's not going to happen to me. No, it never happened to anybody in my family. But something that our organization and Together Against Breast Cancer always keeps saying is the prevention. It's time to go get your mammograms done. And one thing about our community is the fact that some of us come to the US not with our real birth date. We come with a different birth date. So sometimes it's like, nope, I'm way too young. I don't need to go in. But what is our real birth date? Like, just go in, go see if you notice anything. So working with Hawa, Together Against Breast Cancer, and her coming in to our organization and actually teaching the women on how to do self-exam, and then talking about the HPV vaccine, getting the girls to go at the age of 12 to go get their first dosage of their vaccine on. It's something that we just need to keep talking, but the education is the biggest portion of it. We need to educate. Just keep educating, and then one by one, every time that Hawa and us have a conversation with the ladies, which we have at our site, it's like just an organic conversation where this is something that's real, and then just kind of talk to them throughout the entire process of getting a mammogram done, and seeing that, don't hear from word of mouth, someone said, oh, it's such a painful process, so I'm not going to do it. But that one little moment that you spend in that painful process can be a lifetime of you preventing something that could potentially happen to you or your family members, such as colon colonoscopy, getting that done. So it's things that we've seen a lot happening in our community, And then we just hear it when you wake up one day and you hear so and so on passed away from cancer. And then you go into the funeral and you find out, and it's like, well, we didn't know. We just thought something, or we just found a lump, like we didn't think big deal out of it. We did our own holistic things. We just did the cultural stuff, but we never went in. And then at the end, you find out that you lost a family member because of something that could have, especially with cervical cancer, some things that have a vaccine out there already that can prevent it at an early age. So thank you so much. And now I want to invite Dr. Sean Ehlers to the podium. Dr. Eller is a consultant and a chair of the Division of Outpatient Consultation, Department of Psychiatry and Psychology at Mayo Clinic in Rochester, Minnesota. She joined Mayo Clinic in 2005. Dr. Eller is a board certified clinic health psychologist who simultaneously holds full faculty privileges in the discipline of clinical and translation science within the Mayo Clinic Graduate School of Biomedical Science, with a focus on integrating cutting-edge psychological care into disease-focused treatment programs and digitizing front-end psychological care to enable broader access for all patients. Please, Dr. Eller, come up.
Thank you. Thank you all for coming. I just wanted to point out how important it is for people to be here and hear this information. And later you're going to hear some heroic patient voices. So be sure to let them know what heroes they are for coming and speaking and being heroes and pioneers within their communities. So, should I try this or? Okay. Let's see. Oh, it just moved. You moved it? Okay, sounds good. So we know that when we hear a talk, we usually remember about three things. So I'm going to put that up front. If you remember nothing else from what I say, please remember these three things. We need to normalize talking about cancer and how stressful and horrible it can be. We need to be able to treat cancer stress as normal. It's normal to be scared. It's normal to be sad. It's normal to be anxious. It's completely normal. And for some reason in our society and many cultures, can you all hear me? Yep, okay. A little bit louder. Okay, thank you. In our society and in some cultures, it's treated as shameful or stigmatizing to have cancer. So we need to just start talking about it. It's something that's not contagious. It's normal to be scared. It's normal to be sad. So again, emphasizing how heroic our patient voices are at the end of this session. So I already went into number 2, just make it normal to talk about it. And number 3, treating cancer stress. It's normal, it's even expected, and it's treatable. I'm just going to take you through this here. So 50% of patients with cancer endorse significant stress. And I have that word underlined there, endorse. So how many, I want you to raise your hand if you know somebody who's had cancer but doesn't talk about it, doesn't talk about the stress. So we're talking about a lot more than 50%. It's just 50% of people that say and talk about being scared or sad or anxious. We have national guidelines. Our cancer centers are required to ask you, if you have cancer, are required to ask you about stress. Make sure you have that conversation with your team. It is a requirement, and they are required to help you manage stress as you go through cancer treatment. Best evidence treatment for cancer distress is cognitive behavioral therapy, specifically designed for cancer. It is hard to find in the community. And even at Mayo Clinic right now, I'm the only doctor there who does this work. I obviously can't see every cancer patient who comes through Mayo Clinic. but we just had a big hiring package and we are growing significantly and we're working very hard to put this best evidence treatment out as available to everyone. We're also creating some digital products like applications. So some of this information can be shared just by your phone or on your computer. And then state of translation. So at Mayo, we have a program, a small program, where we have this best evidence integrated into the clinical practice. That's fairly rare right now, but we're really pushing that nationally to get it expanded everywhere. So this is a complex slide with a lot of things on it. The main message I want you to get from this is cancer stress involves many different things. So practical things like finances, transportation. Can I afford my treatment? Can I find a way to get to the cancer center? Emotional responses, that fear, sadness, anxiety. Spiritual. Often you'll hear people question their faith or be angry at their God because this isn't supposed to happen to you when you're faithful. And so how can this happen to me? I'm a faithful person. So those struggles are very real. Emotional support. Because of stigma, sometimes people don't talk about it and they feel isolated and alone. And physical and behavioral distress. So there's a long line of symptoms there, but people can feel really exhausted and fatigued, have difficulty with sleep, and other things like that. The bottom part of this slide contains 14 different disciplines that we have at Mayo Clinic that help people manage these symptoms. I lead a group of these disciplines, and we are working very hard to bring everybody together to work as a very large team. Our goal is for anybody who's diagnosed with cancer that's going to come to the Mayo Clinic to reach out to you before you even come to the clinic to start these conversations. So that's where we're headed, hopefully in the soon in the future. So I mentioned that there's a mandate. We're required to screen for distress. This is actually what we're required to do. Screening means we ask you about cancer stress. And then if we see that you screen positive, we ask you more about it to assess it. And then we triage you to the right clinicians, because remember, cancer stress is treatable. And then we keep monitoring and we make sure that you get better. And if you don't get better, we find additional treatments and we keep working with you and partnering with you until you feel better. This is just a summary slide from our own small program that we have here. This is cognitive behavioral therapy for cancer. And we have had 100 patients go through this program, and 99 of them said they would recommend it to friends and family going through cancer. So we have really good support from our patients who have helped us grow this program. I'm going to read those quotes there. This program gave me a different perspective to approach life. I would recommend it to every patient going through cancer. Life-changing. I wish I had this care starting at diagnosis. It would have been much easier. So this is what we're working to make accessible for every patient at Mayo. Partnership is really important. On this slide, you see what we call the quadruple aim of healthcare. So at the top, I've mainly been focusing on the patient experience, and our aim there is to reduce unnecessary suffering. We know how to treat stress, so if we don't treat it, we have unnecessary suffering. When we have unnecessary suffering, we have worse outcomes. When you're fearful and a lot of energy is being spent in fear and sadness and anxiety, it's hard to focus on your treatment. It might be hard to take medications. It might be harder to get to your appointments. So it's harder to follow the treatments of the oncology team. Having higher symptom burden can be related to more visits to the ER, longer stays in the hospital. So we also see reductions in those things, which is very good. And because patients feel better, we make the job easier for our clinicians. It's hard being a doctor or a nurse who takes care of unnecessary suffering every day. So when they see the suffering of their patients come down, they feel better and more energetic and happy about work. So this is even a larger model. The orange circle there is the patient, the individual. But care and health outcomes don't stop there. The next level, the green level, is interpersonal, the relationships we have, friends and family. We help each other get to appointments, remember to take medications, provide a listening ear. Organizational. I've talked about some of the things we're doing at Mayo. Those are organizational efforts that help people get the treatment they need. Community, here we are. Events like this are very important to help create that community fabric, those connections in the community and the connections with the community and the organizations. And then if you take it to that top level, we're talking about policy. I mentioned we have a mandate. Mayo Clinic in any comprehensive cancer center is mandated. If they want to be certified, they have to ask about distress. That helps us a lot because it's required. I wanted to give you an example of some of our efforts to reduce healthcare disparities and include everyone. So I work with a liver cancer program at Mayo. It's a new partnership. And what happened is they have the best cancer treatments. If you have liver cancer, this is the place to be. But their patient advocacy board said, we love that you're giving us the best treatments, but we're not tumors. We are people and we suffer and we need help for our suffering. So those cutting edge doctors who oversee those cutting edge medical treatments reached out to me as a cancer psychologist and said, would you like to partner? And I said, yes, this is perfect. So what we're doing is we're just starting with a simple needs assessment where we're working with the patient advocacy board to survey all the patients within that group to talk about their experience. What symptoms did you have? What was your unnecessary suffering? What was helpful? What was missing? And the more people that participate in that survey, the more representative we are of the community. But we know there are many communities that have a history of discrimination and horrible treatment by majority culture. So there's mistrust. And sometimes it's easier just to not engage with surveys like that, especially if you don't know who's sending them, because you're worried about what they might do with the information or if they really have your best interest in their heart, because you've experienced abuse and discrimination in the past. You know that can happen. So how do you know this isn't it? So what we've done is we've partnered with our culturally specific patient navigators. Patient navigators in the cancer center are people who reach out and they literally help you navigate Mayo Clinic, your treatments, where to go, who to talk to. And our culturally specific patient navigators are members of communities. So specifically, I'm working with a member of a Native tribe to reach out to our Native patients, and a member of our African American and Black communities to reach out to those patients. So they're members of the same community, so there's better trust there, understandably. And they're helping us reach out to make sure that people who don't complete the survey are doing that because they really don't want to. It's not because of mistrust and other barriers that prevent people from being involved in the design of healthcare. And in this way, we hope to have all those voices input into our program. So we're designing for everyone, not just majority culture. So Mayo Clinic has the Bold Forward 2030 plan. And whenever I talk about it, I say we're going to treat all prognostic variables, everything that relates to outcomes, not just the biomedical, not just the cutting edge medical treatments. And we're going to empower patients via psychological skills training, that cognitive behavioral therapy, to optimize distress, control symptoms, and have better outcomes. And I'll stop there and look forward to taking any questions at the end. Yeah, thank you.
Thank you so much. That was a lot too. We learn a lot every time. Now please move your attention to the screen as we listen to powerful stories from patients presenting West Africa, Hispanic, and Cambodian communities.
I am from Guinea. Hello, everyone. It is my honor to be able to share my story. My name is Hawa Kamara. I am a single mother. I have a daughter who's 12 years old. I am from Guinea originally. Guinea is in West Africa. And I've been living in the US, or I should say, the US is my second country. I am also a US citizen, and I went to college at St. Cloud State and have lived in St. Cloud for many years before going to Guinea to care for my mother. My initial reaction when I was first diagnosed with breast cancer was a total shock. I was living in Guinea, caring for my mom, working at a bank. And it was my daughter and I, we are huggers. And she hugged me one day and told me, "Mom, your left breast is hard." I thought, really? And she said, "Yeah." I went into my room and checked. Indeed, it was very hard. A few months went by. I decided to go to see an oncologist. When I went to see this oncologist, he decided to do a biopsy. This biopsy was done, and to my shock and surprise, after he had retrieved my flesh and put it in a cup, he gave me back the cup and told me to see another doctor the next day and give him the cup for them to send this for a biopsy. I was so shocked by this reality, and I know everything about it was wrong. But then again, I was desperate for answers. When I went to meet this doctor, he was on the street having coffee and tea with his friends. He came to my car. I gave him the cup, even gave him money, thinking that it would probably speed up the process. But as soon as he turned, I started crying. I cried because I knew everything about this was wrong. I went to St. Cloud, went to my primary doctor, ultrasound, mammogram, and during the ultrasound, the doctor decided to come in and offer a biopsy. 3 days later, a nurse called me. I was positive for breast cancer. And I asked her, what does positive mean? And she said, you have cancer. And I screamed, what? It was as if a ton of brick was certainly on my head. Immediately, my sister flew in, and on that Wednesday, my sister landed in St. Cloud, and Thursday morning we were at the hospital to get the news. I was informed that I have stage 3 inflammatory breast cancer. I swore my sister to secrecy. I am a practicing Muslim. Immediately, I stopped praying because I was mad at the world. I was mad at the universe because I thought I didn't deserve this. As I was now on a journey to start chemotherapy. I grew up in Guinea seeing cancer patients reduced to nothing but their tumor. When you're sick and you're told it's cancer, people would not eat with you because of lack of education and misinformation. Of course, they think that cancer is contagious. In my humble opinion, in my culture, we need to get rid of stigmas. Also, we need to banish the word condemned when we're referring to patients with cancer. The life that's given to us is given to us by God. Who are you to call us condemned? Most of the people that also get cancer, they hide it. The family hides it because they think if you have cancer, some or most, you must have done something to bring it on to yourself. You must have been evil, and so this is karma that you have cancer. We are in 2023, and a radiation therapy center is inexistent in my home country of Guinea. In my culture, we need to do better. We need to treat every cancer patient with love and dignity. We all deserve this, especially when battling a monster like cancer. From my experience battling my own disease, I know for sure that mental health is half the battle won. We need to stop hiding our disease. It is important that we have doctors that are culturally aware to help us navigate what we're going through. Because if they're not culturally aware, they cannot relate to the realities that we face. They cannot relate to how we grew up and what we grew up seeing with regard to cancer. To prevent cancer, I think it's very important that we start teaching our young daughters about self-breast exams when they have their periods. When they are young adults, they would realize, or they would be able to catch any changes that would happen in their breast or in their flesh. That, to me, would save lives, because if there are any changes, it could be caught early instead of late. My last advice also to survive your battle is to become your doctor's ally. Know your disease. Ask questions. There are no dumb questions. You are the best advocate for yourself. And my suggestion is that you make sure you are there for you. You have to be there for you first before anyone else can be there for you. I hope these advice helps. These advices help. And I'm grateful to be able to share my story with you. It's humbling and it's my privilege. Thank you. So here it's me, back to reality, you know, without the wig and the hair scarf. Whew, I couldn't wait to get it off. Mwah.
Honestly, I really wasn't in shock. To me, it was just another illness that I had. But when they started talking about it and me having to go through the chemo and all that, it was shock. I was in shock. I didn't know what to expect out of it. I didn't know how to tell my family. The first thing that came to mind was the burden that my wife and the family was gonna have to deal with me, and it happened throughout the COVID. You know, when COVID came in, so yeah, it was a surprise. Among our family, we never discussed about cancer, because it never did happen. So I wasn't aware of we weren't aware of the symptoms. Growing up with a large family, we didn't have the options either to go to doctors or afford a doctor or do things that will keep us healthy, which is hard on a large family like that. And my mom and dad couldn't give us as much as they could, you know, trying to be healthy at all times. I started working in the fields, in cotton fields, at a very young age. I'm number 10th on our family. There's 12 of us, 6 boys, 6 girls. That's all I've been doing all my life, working labor, hard working work. I had two back surgeries back to back. And on my second surgery, that's when they found the cancer, which was a surprise for me. Having an interpreter explaining to us what other symptoms as to where people can get cancer, or how does that cancer come into. I have no idea how I got it or how it got there, which was something that I had no idea. I was going to come out with cancer. I went through chemo about 6 months. I don't like myself as who I look. I see myself and I get depressed. I used to weigh a lot more. I used to weigh 180, 182. I'm down to 157. I'm keeping it stable. I don't go down or up. I just stable. I do see at work that they treat me different. They look at me different. They gave me less work to do. I'm thinking because they think I can't handle it anymore, and that kind of depressed me. It kind of, it kind of hurt me a little bit because I was doing a lot more. I don't like to sit around. I like to be very busy, but they kind of slowed me down. And Lisa really, she helped me out through all this process, working at the same time, take me to the chemo, take me to appointments and all that. That really hurt me, and it was a struggle for her. And being that it was COVID time, my boys they couldn't go to the Mayo and visit me or see me or come, or so it was really depressing. I do have two nieces. A niece that passed away just recently, not too long ago, and I do have another niece that has cancer also right now. And when I found out about that, that was kind of depressing. And then come to know that I have it too. So now our family are very aware of that. So we talk more about it. Even though they don't live in Minnesota, but they're in Texas, all of them. But we keep in contact on the phone. I think I have 3 boys. I think the one that took it hardest was my youngest one. He took it real hard, and he still does. But yeah, I mean, growing up in a big family like that, we really didn't talk about it that much until now, until my nieces and all that came. But yeah, doctor visits, stay healthy, eat well, exercise, whatever is needed. I'm pretty sure it'll help you in the long run, for sure. Honestly, what really hurts me is that I'm glad that we caught it early, because I want to be around. Since I'm a grandparent now, I want to be around for my grandkids. That's what really hurt me, that when I was diagnosed with cancer, because I want to be around for them. And I guess I just want to be around more. I mean, I'm not ready to go down. I'm not ready to be, I just want to keep going in some way. I take it day by day. I don't think about it. I don't think about it at all. I take my medication every day, and really right now I'm just living the life. And I'm going, Mayo Clinic is taking real good care of me, and they still are, and I'm greatly appreciated. And yeah, I take it like every other day. I'm happy, active, and willing to do whatever I have to do.
My name is Tracy Sam, and I got diagnosed with cancer 2009 September. But I don't know exactly when, but that's when I started having pain in the left side of my breast. And I was scared to tell anybody about it because I thought it's a normal pain. And I used to work at St. Mary's Mayo Clinic for a total of 15 years until when I worked at Mayo, I used to pass out all the time. And they would call a code 45, which is a medical emergency in the hospital. And then I get rushed to emergency room and do all this workup, and later to find out I had cancer in my breast. But when they find the cancer, it was too late. It's a stage 3 already. And I was devastated because during this time, things weren't going well with my husband and I. My husband and I, I went to marry him back home, because culturally, I was following my mom's and dad's tradition of marrying, like a arranged marriage. I had my first child in 1999. 2009, we were married 10 years. 2009 of September, I had this pain. So going to have it checked out with my primary doctor at Mayo Clinic. I was scared. I was scared to find out the news. I thought I was going to die. I was thinking, how am I going to tell my family? How am I supposed to tell my husband? How am I supposed to tell people in the community? Because there's a stigma about she has cancer, stay away from her. And I kept it to myself. I had anxiety, depression, agoraphobia. I had gone to Zumbro Valley for mental health through a social worker, psychiatrist. I felt like killing myself. Actually, I committed suicide 4 times, but unsuccessfully. When I had the courage to tell my husband filed for divorce. My husband wanted custody of my son. He's my only child. And he had told the courts that I'm going to die soon, so he should have custody of our son. He wanted to take our son back to Cambodia, which my lawyer luckily didn't let that happen. So I got sole custody of our son. Yeah, finally, our divorce was final, actually March 28th, which is today, 13 years ago, 2010. I had gone through surgery, remove both of the breasts, mastectomy, and I had chemo, which started in March of 2010, and then radiation, which started in May of 2010. And while I had chemo, I almost died because of allergic reaction. I had anaphylaxis from the chemo. Doctors and everybody was afraid that they couldn't bring me back. I had surgery, chemo, radiation. I had hormone therapy. Hormone therapy about 5 years, being on tamoxifen. But I stayed away from my people. I stayed away from going to the temple, which really I am involved in the community. I volunteer. None of my community members were supportive. The only support I had was from my mom. Even I cannot talk to anybody at the Buddhist temple because the community only known me as, oh, her husband divorced her because she had cancer. Like, if you can't find help and support in your own community, in your own culture, you always can reach out to the medical community. They have a good medical community here in Rochester, Mayo Clinic, and medical providers can always show support for you and answer any questions that you have. And they supported me emotionally and mentally, and that's why I'm still here. I wrote my life story, and Newsweek published it, the Newsweek magazine. They published it, and I got a $500 grant from my story of living in Cambodia through the war, and my mom having to take us out of Cambodia how she got two of us, three of us out of Cambodia. What also was included was how my dad was separated, and she had to bring the kids, us first, into Thailand border. We came to America first, and then, yeah, all that was included in the story. I had an abscess in my left hip during the war because illness and stuff, and it ate up the joint bone in my left hip. So coming to America, they tried to fix it. So in Cincinnati, Ohio, doctors couldn't fix it. And so we went to California. They didn't know how to fix it either. So that's how I ended up here in Rochester, Minnesota. Mayo Clinic agreed to fix my hip. So that's where I had a hip fusion, and I am able to walk again. If you're feeling pain and symptoms in your breast, or you feel like a lump, like I did, and go get checked out. Go see your doctor. I went to see my primary doctor, and they did all the testing, and that's how I found out I had cancer. If you don't get checked out, you never know. Doctors, nurses, therapists, people at Zumbro Valley, people like at Mayo who work in psychiatry unit, they were all there for me while I was going through this. And I really appreciated them, and you know, they're the ones that, the reason why I'm still living today, or else I could have died. My fourth and final attempt to commit suicide, which failed again. I took all my medications, cancer meds, seizure meds. It's like maybe over 50 medications, but I didn't die. I don't know why. Maybe there's a purpose for me for being in the world. But my son, who is, I would say, I don't know how to word this, the one that kept me going is the one that I think about today, that is the reason that for living.
Those are very deep videos. I was sitting next to Hawa, and you can hear me now. Yeah. We want to invite the presenters and the storytellers up so we can do our Q&A. We have some microphones.
Sit here.
Yep, yep. Some microphones. Manal's gonna come up. Anywhere, take a second. Anywhere. Button on the mic, press. If you have any questions, please raise your hands, and Manal will come around with the microphone, and you can ask your questions.
Can I start with a comment?
Yes.
Can we have one more round of applause for the patient heroes that we just heard from? These are the people that are bringing it back to the community and saving lives in their communities.
You have a question? I'm closer, but I'll get to him.
Hi, thank you for the presentation and very deep stories that make sense. And I think these events are really helpful because it helps a lot of people who are not really educated in cancer. So thank you again for the presentation. And I have a question for the doctor. I follow a little bit about the cancer. What are the risks internally and externally? I'm from Africa. And I know you were mentioning about the red meat being a high risk. Red meat, you say it's a high risk. And I know some countries in Africa, that's what we eat like almost every day. Right? And I would like to know what are the, the cancer, what the risk of those for eating red meat, how likely they can get diagnosed with cancer. Because myself, I came from a country where we consume a lot of meat. So I just would like to have a deep understanding about the risk of that.
Thank you for that question. So in a lot of parts of the world, it's difficult to really choose what type of diet that you have. It might be that where you live, there is, you have a lot of livestock, and that's the primary source of food. And there are people that primarily consume fish, and then there are people that live in a farm, and a lot of their source of food is from plants. And so sometimes there's really no choice, but when you have a choice to eat different types of food, in that case, you try to limit the amount of one type of food that you eat. So you can say that, I'm not going to eat any red meat, but I'm going to eat a lot of fruits and vegetables. Then you're missing out on the nutrients that you will get from red meat. So you might be low in iron, for example. And if you consume too many carbs, then there are a lot of problems with that as well. So the biggest message that I can give people is eat a balanced meal. And then with red meat, I'm not sure of the exact percentage of risk that you would have if you only consume red meat, but there are probably studies out there that look at people who have a primary diet of just red meat and the amount of risk of cancer, or the amount of incidence, how common it is to have certain types of cancers. And I'll look back into that study that looked at colon cancer risk, and I'll send the information to Kylie, and that could be shared as well. But one other thing that I wanted to mention during the presentation is that cancer is everywhere in the world, and it's just that in some parts of the world, there's now no regular screening. And so people are not aware of cancer as the cause of illness or as a cause of death. So that unless it's visible on the skin, so somebody could see there's a tumor there and that's causing them to feel sick. But when it's internal, then a lot of people without any regular screening or awareness of the symptoms of cancer then become very ill, and ultimately they pass away without there being any knowledge of what exactly happened. So the person would be told, yes, they just got sick and died, or they reached an older age and then they died, but there's no reason that's given. And recently I do a research on cancer screening disparities, and starting with the community that I'm most familiar with. I'm originally from Somalia, so I'm looking specifically at the Somali community here since we have a larger population here. And I looked at cancer incidence, so the type of cancers that occur more commonly in this community here in Rochester, and then also looked at cancer incidence in Somalia and then just in general in the United States. There's not much information about it, but there is a higher incidence of certain cancers in the Somali community that have been reported in just only 2 studies in Somalia. And then we're trying to describe the cancer incidence here in Rochester and Olmsted County in a study that's going to be published soon. So cancer exists there, and I just want people to know that it just depends on where you live and what's available to you, the resources that are available to you to determine if there's a higher risk of certain cancers.
Thank you. And I have another question. Sorry. My second question is, we know this microwave we use home to warm the food. Physically, they said it's some X-rays that hit the food, that change the molecule, that hit together. That's why it gets heat. You get the heat, and you get your food warm. And I would like to know the risk of warming your food in the microwave to get cancer.
So I haven't looked at this recently, but I remember looking at this because I remember when I was a child, my mom saying something similar, that heat your food in the microwave. And I think there are places in the world where it's actually avoided using microwaves. But like you said, the microwave heats food by making the molecules move fast, and then that heats it up. But I'm not aware of any transfer of the changes in the food being sent to the person who consumes it. And if that was the case, then I think there would be a much higher risk of much higher incidence of cancers here in the United States than anywhere in the world, because we use microwaves almost every single day. So I think it's a low risk.
I'll just add one thing there. There is a little bit of literature that says that microwaving plastics, so the bowl or the plate that you use, can be bad for your health. So it's safer to use like pottery, ceramic type plates and bowls.
Great points, because yes, make sure that the bowl or whatever your microwaving is microwave safe, but definitely avoid plastics and things that can leach into the food, and then that's what have a higher risk.
Thank you, everybody, for such a wonderful presentation and also the information. I have been surprised about the 40% of risk on cancer cases when there is obesity and overweight. That it's a number that has hit at least my concerns for the past 10 years. I don't think we are all aware about that. I see it doesn't sink in, like the tobacco use. Please stop it because it has a lot of toxins. But that 40% for me is huge. So what are we going to, or how are we going to address in an education way to most of us?
That's a great question, because now obesity is becoming more prevalent in the United States and in most of the developed world as well. And right now, 1 in 3 people have obesity here in the United States, and still heart disease is the #1 cause of death in the United States. But over time, we expect that cancer is going to be the #1 cause of death, because there has been a lot of effort put into preventing cardiovascular disease. So smoking, campaigns against smoking, and then medications like aspirin, Lipitor, cholesterol medications have been really helpful in preventing heart disease. And also the treatment of heart disease has become a little bit more specific, getting people treated very early and quickly. But for cancer, it's really, screening is the #1 thing, and screening recommendations will change over time, because right now with what we saw in colon cancer screening age is 45 instead of 50, and still it might change. It might become a little bit earlier, because there are certain cancers that are being detected in earlier age, and also because we're learning more about different demographics. So cancer screening in general right now for colon cancer is 45, for breast cancer is 40, but in a different subsegment of our community, it could be that these cancers occur at an earlier age, or it could occur at a later age. So then there's this whole movement towards personalized medicine, and then knowing more about how our community is broken down into different segments and tailoring the recommendations to each individual.
I wanted to add to that from the patient's point of view. From our different cultures, I think it is very important that we educate. Why do we educate? Because like the doctor just mentioned, with the cancer, we, first of all, are not used to these screenings because we are thinking, oh, well, it won't happen to me. And the fact that we have an age bracket here, like 40 is when you start doing your mammograms, it has become like a rule of law, in certain people's mind, but it shouldn't be. I had my cancer when I was 32, right? And a lot of young adults today are being diagnosed with cancer. I've seen a patient who's 19 and who has breast cancer. So I think that the struggle right now is that the fact that the age is at 40 and plus, how do we get those that are younger access to getting screened? Because experiences have shown that it does happen to younger women. And then insurances don't cover when you are under that age bracket. And so those are the kind of struggles and information that we really need to convey to our different communities so that we are aware. And I know that there are possibilities with SAGE, for example, and community health right there will give you more information about that. And it is very important to be aware of those tools or those resources that are available to us here so that we can guide our communities to them. So that's just what I. Thank you.
Just to follow up on the question about the obesity. So right now, the quality of the food, a lot of the processed food that's being consumed, especially at a younger age, is one of the things that's contributing to, childhood obesity, but then that also leads to a higher percentage of the adult population then also having obesity. So starting much earlier, it's not that, suddenly people as they become adults then develop obesity. Yes, metabolism slows down as you age, but then kids are eating a lot of food that's not very healthy, and then obesity is developing earlier. So then that's also one of the reasons why obesity is occurring. There are some treatments that are available to be tailored to the specific person. Besides diet and exercise being one of those things, accessibility to healthy food may not be feasible for everyone. So I think that's something that if despite somebody's hardest efforts with exercise and diet, they've not been able to achieve weight loss, they should talk with their doctor, maybe figure out if there's an underlying health condition or if there are treatments that can be offered.
Okay.
I wonder if Paula could tell a little more about inflammatory breast cancer. It's rare, but it's very aggressive, and the symptoms are different from most other cancers, breast cancers.
Absolutely. From a patient's point of view again, I usually like to make that difference. There's a doctor, there's a patient. So yes, inflammatory breast cancer, unfortunately, is very prevalent in the African and African American communities and other cultures as well. And it is very sneaky, very hard to discover. Because when I go from my own experience, I did not feel any symptoms. For someone who was at a stage 3, I was going through life, didn't have anything that would indicate that I had this going on until I had that hug. But then when I went and observed it, it had a feature that in French is called peau d'orange, but it's like you see how an orange is, the outside of an orange, it has these little dimples in it. So usually when you have inflammatory breast cancer, that's how it looks. And I didn't know that. I didn't know that because in my head, I thought cancer happens to women in their 50s. Yes, I'm educated, but I thought, oh, yeah, in the 50s, I don't have to worry about that. So even when I was, in my country first, I was misdiagnosed and all that. And when I came here to do all these checkups, believe me, when I was doing all these checkups, I still thought in my head, no, cancer, I'm just 32. It can't happen to me. And then when I heard the news, like I said, it was just like, they made a mistake. And I actually came to Mayo Clinic because I wanted a second opinion. That's how I just couldn't believe it. Again, I was stuck on this age, thinking it only happens to older women, And with inflammatory breast cancer, I have to tell you that the treatment is really harsh. It's harsh because the skin is involved. And so after radiation, for instance, when you go to mastectomy, the skin also has to go. Because of that peau d'orange in French, but that structure of the inflammation of the skin. So when you do a mastectomy, you have to do a complete one, which means no skin can be spared. So that's one of the things that probably others with different, type of breast cancer don't have to, they can spare the nipple, spare the some part of the breast, but with inflammatory breast cancer, you don't have that luxury. The skin has to go with it. That's one of the hardest things. And then when you go to radiation as well, it's not just the breast, the skin also has to be radiated. And by the end of that radiation, you come out with raw meat. Seriously. I mean, it sounds frightening, but again, it's a process. And so that's why in my video, I'm saying that for me personally, I think half the battle is the psychological part of it, because treatment is hard. And the weight mentally is heavy. And so, especially in our community, going to a psychologist, for example, is considered you're crazy. You go to a psychologist, it's like you're stigmatized that you went there because you're crazy. So we're not used to going to a psychologist. And even if we're offered it, we'll say, oh, no, I'm okay. Because we don't want to get stigmatized that we're crazy. And that is it's an obstacle to getting the care that we need and deserve. And so if we don't go past those cultural barriers, we will not be able to get the care that we need and deserve. And when we have that help, that psychological help, believe me, everything gets better with time. And so for me, my advice is with anyone going through this is it has to be both. Just the physical health and the mental health. Without one or the other, for me, there's no success. And so with this particular cancer, I think there's a lot of struggle to go with it. And so with, the help of the mental part of it, I think we can see the light, basically. And one thing I do want to, since we have a psychologist from Mayo here, that I do want to plead with Mayo is that we have psychologists that are culturally aware. That is to me very important. Because like I say, for those that decide to be allied to our doctors, and really, because doctors too, they're human. I mean, they can read our brain, they can read our minds. So we have to be open to them and tell them really what the struggle is. But what happens, or my experience have been, you sit there with a psychologist, you tell them your whole story, you finish, and they said, okay, can I give you something to help you sleep? I don't wanna numb or sleep my stress out. Personally. And when I sit there and give all this story, and then you give me that feedback, I feel like you didn't get it. You didn't get it. Because if you are culturally aware, one, you would know that from our culture, like for somebody who's never seen anyone survive from cancer, all they see is somebody pass away from cancer. To them, cancer equals death immediately. There's no discussion. And so my hope, seriously, is that our doctors, our psychologists are very much culturally aware in order for them to be able to give immigrants and others the care that they also need and deserve by understanding where they're coming from. Thank you.
I would like to ask doctor a question. When you get cancer from the work area, like I used to work in the lab with all different kinds of chemicals like ethanol and stain, and it says cancer causing chemicals. So can cancer be caused from your workplace?
Yes, that's one of the risk factors is the environmental occupational hazards. Sometimes it's labeled in the products that you use for work, and other times you're not aware of it. And then over a long time, the amount of that chemical you get exposed to and the time that you spent in that exposure can damage, parts of your body and cause cancer to develop. And sometimes that can cause one of the more, rare cancers. For example, in one of the slides I mentioned that blood cancers can be associated with exposure to benzene, for example. It's a type of chemical related to petroleum, and also fertilizers and things like that can be associated with cancers. And it's definitely possible. So that's something that you can't say 100%, but and not everyone who's exposed to it can develop the cancer. So it's just, yes, there's a higher risk associated with it. So protecting yourself in your workplace is the best strategy if you know about that ahead of time, what you're going to be working with.
So I think that my cancer was caused from working in the lab at Mayo.
And the other thing is, most cancers, or the most common cancers, are the ones that are affecting the majority of the population. But then we have a segment of the population that doesn't fit that circle, and so they might develop cancers at an earlier age or at a way later age than is typical. And so that's something that we have to be aware of when somebody comes into the clinic and they say, hey, I'm not feeling well, or this looks abnormal. And so we have to keep an open mind and not think, okay, well, this person doesn't fit into the circle, so it's probably not, cancer, it's probably not this condition. And then cancer might not present like it normally does in most people. And so, for example, I've seen a male patient who had breast cancer, and that's extremely rare, but it was sporadic, and it happened. And that's not to say that most men are at risk for breast cancer, but it's possible because it's a cell. Everyone has cells. Cells can mutate and then cancer can develop.
First off, I'd like to thank you for your dedication, your sacrifices to your child. Anyway, I just got diagnosed with possible cancer. Now, how they say possible, or they really high suspected, runs in my family, you know, and I've outlived my brothers, sister, and, all my uncles on my mother's side, they all passed away before 66. But it's a shock to me, and I was a smoker, but I don't blame it on smoking. It could happen to anybody. But what I want to say is, everybody should get physical once a year. You wouldn't believe some of the things they find it's minor at that time, but then you guys give us medication or whatever we need, you know, started off as blood in the urine, you know, been getting it for 20 years. I mean, it's so many tests you guys have done that they couldn't find a trace of why it's happening. But in the process of all that, right? CT scans and what they call advanced CT, PET scans, you know, they take all these doing because, hey, a nozzle grew, you know, they didn't expect to see a nozzle, you know, what it's grew, it wasn't that last year. So 10 millimeters this year. It needs to be looked at. So they say, you guys are great.
To say something, well, I have cancer at 32 also. Inductive. They say. Ductal carcinoma? Yes, stage 3. I agree with you, there are stigmas against our culture. Like, when I had cancer, people say it's because of me, it's my karma. I have done something wrong in my past life because why I had cancer.
Same thing in my culture as well.
Just a comment. I'm a survivor, and the only reason I'm a survivor is that 8 years ago, we were back home for Christmas. And about 2 days after we got back here to Rochester, my sister called. And she says, take it for what it's worth. But my brother-in-law had nagged him that he said, there's something wrong with Jerome's neck. So what I did was I went in, and sure enough, they took a little hunk of my tissue. And that's the only reason why I went in. And my message to people is if somebody says something to you, or if somebody says, you know, there's something different about you, don't just wipe it away and say, you're full of crap. But go to the doctor, have it checked out. Maybe there is nothing, but in my case, there was some. So that's one piece of advice that I would give to everybody in this room. And again, thanks for your stories. Thanks for the information. There was a number of things I learned today. And I thought I knew a lot about cancer, but keep up the great work like this gentleman here said too, because of the research that's happening here and all over the countryside, someday we are going to beat this blankety blank thing. So good luck to all. Thank you very much.
I can just add a comment to that somebody observing an abnormality. There was a news reporter not too long ago who somebody was watching. I don't know if it was a physician or who it was, but they noticed that her neck was enlarged and called the station or something. But eventually, she was diagnosed with thyroid cancer, I believe. But it was caught early before she really noticed it. So yeah, to listen to what other people are saying, just to, even out of curiosity, just to go get checked out.
Mine is just a quick observation, given to me by my primarily interaction with Hala and my own wife and 3 or 4 other women that I've known involved with cancer, which is the observation is whether you are the dominant community in your society, whether you know, one of the smallest communities in your society, yes, that absolutely has influence on how much the quality of care you get. I agree with that totally. But I think there's one thing above that, and how it has convinced me of this, is you have to be your own advocate. If you want good health, you have to practice a good lifestyle. And I shouldn't be saying have to, but practice a good lifestyle. And secondly, don't be bashful. You have to be polite, you have to be considerate of the people within the profession, but you have to be your own advocate. If you want good health, you have to assume the responsibility for it. I hear way too many people bemoan what went wrong in the health care they received, placing the blame on the health care as opposed to taking the responsibility to pursue the good health care they need. So just an observation.
What I do want to add to that is that this I'm addressing is just especially the Muslim community. And I see we have some members here, and I'm also Muslim. We are quick to say that, oh, it happens to me, it's God. And then we sit there, refuse, or sometimes, again, lack of education, to seek proper care or proper preventive measures. And I'm here to say that, yes, God is there watching all over us, but believe me, God's not going to come from there and do the work you need to do here. And we have to be clear on that. You have to take care of yourself. That has nothing to do with God. And by taking care of yourself, you are loving your family through that. Because when you take care of yourself, you're avoiding suffering from your family. So let's not be quick to throw that blanket and say, oh, it's God's will. And then, if it's meant to be, if I'm gonna survive, and then, no. God puts you on this earth for a reason. And you should fight for your life. God gave you this life. So my advice to our community, they usually throw that, religious blanket and say, oh, it happens to me, this is God's will, so I'm not gonna do nothing about it, because God wanted this to happen and all that. No. We need to fight for the life that was given for us. Because our families, our friends, our community, they deserve that. And we deserve that too. So I was just gonna throw that out there too, for a lot of immigrant community, not just the Muslim too, just to know that it is important that we take care of ourselves and we think about not just ourselves, our kids, our partners, whatever we have in our life or our loved ones, period. Thank you.
If I could add, I would say that preventive health is just as important as eating. You're eating so you don't starve. You're drinking water so you don't get thirsty or become dehydrated. So if you have to go find your food, if you have to go eat and drink, then you have to take care of your body in other ways. And if there are preventive measures that are available, seek those out. If there are treatments available, seek those out. And there's nothing wrong with adding prayer to that, as long as you're taking the action. So that's something that I just wanted to add. They're not mutually exclusive. You can pray and believe that there is something that is the will of God, but at the same time take action to do the best that you can, because that combination is what works best.
I was curious if with Tracy and Hala, are you cancer free at this time? How are you doing now?
At this time, yes. But on days that like this weather, sorry.
Tap right into a tree.
On days like this kind of weather, it hurts where I had surgery. It's like a throbbing pain.
Unfortunately for me, I'm not cancer free. I am, I've been stage 4 for a while, and, a month ago, I'm now in hospice. And so, but again, I'm not sad about it, you know? And, the reason why I'm not sad about it is that I know that I did everything I could, to battle it. And I know my care team, my medical team has been just tremendous, you know, tremendous in helping me, you know, mentally, physically, and in every way possible, because I was there with them. I was open with them. I was their ally. I made sure they knew what I needed and wanted, and they made sure, and they helped me with that. And so I am in hospice, yes. But as you can see me, I don't live in fear. I don't. I still strive every day to be happy, be as functional as I can as a mother to my daughter, continue to love her through this, and be present for my loved ones and my friends. And so, even with the nonprofit that I'm a founder of, people, if I don't say this, they don't even know that's where I am today. And I like that. It's not necessarily about me, it's about me preventing what happened to me happen to others. And that's why I'm fighting with the nonprofit, to make sure that we educate, we make sure we have access to what's provided to us, and not let these cultural barriers and stigmas stop us from getting the care we could get. And there is a difference between the Western world and, for example, my home country. And today I have the nonprofit, not just in Rochester, but I have it back home. The reason for that is that the battle is different. Over there, believe me, every patient we find is at the late stage, because first of all, the preventive measures are not even there. And the medical system is not to the standards. It's not even close. So the fight over there and the need over there is totally different than the fight and the need here. And that's why here it's very important that we realize we're also privileged to have the kind of care that we have here. So why not take advantage of this and make sure we love ourselves through it, and make sure we are trying to benefit from it so that it doesn't happen to, you know, from generation to generation. And so, yes, I'm in hospice, but really sad. I'm doing fine, and I'm gonna leave without fear. And you know, what happens will happen. You know, we all have an expiration date. That's my mojo. We all have an expiration date. It's not because you have cancer that tomorrow you're gonna pass from cancer. I can walk out of here, drive and have an accident and go. it's a good with my day. So to me, that's how I think personally. And so, and that's what I encourage other to think, you know, when you know you've done everything you can do, I think there's a peace of mind also that comes with that. And so I'm grateful. Thank you.
Thank you, Hawa, for that. That was beautiful. And I just want to emphasize that by fighting, she gave years to her family that she otherwise wouldn't have had. And the wonderful nonprofit work that I'm sure is saving lives here and back home.
I have a question. This is for Dr. Ellers, especially for, I know you work with patients and families as well, especially talking about, the reading or the just, not them knowing that they have cancer. Do you also work with, not just with the patients, but you also work with the families? And just guiding them in, at least I know the families that have a lot of questions and trying to accept that their family members going through that. So, what are the steps, or how do you start with, just letting them ease of telling the patient or their family members, especially, because they know it's hard for them to go through that. So, what's the whole process?
Yeah, thank you for that question. So I'm the only cancer psychologist at Mayo Clinic. So, my work is with a few people, but I have a larger team of 14 different disciplines. And a really great thing you can do if you get a diagnosis is go to the Cancer Education Center, which is in the ground floor of the Gonda building, and talk to the patient navigators. And they're the ones that literally help you navigate barriers to care and find the care that you need. Right now, we don't have enough psychologists to work with everybody individual even, let alone families. But that is in our plan. And we do have people like navigators and social workers that do provide support to families. But I think the Cancer Education Center is a great place to start to be able to find that. And I'll also say that, patient stress level, caregiver stress level, it is about the same on average when you look at the studies. So that is one of the big pushes that I have at Mayo right now, is that we have care focused on caregivers. There are some barriers like billing. How do you make a living taking care of caregivers when you can't bill like you can for patients? The cognitive behavioral therapy that we have, the program there, we have some exercises that patients can take home to loved ones and do together. But that's just a little thing. So what we are working towards, and we need funding and staff to do this, but it's in our vision, is to have a program for caregivers, just like we have a program for patients. And we asked our patients that went through this group, what should we do for caregivers? Should they be here with you in this group? And they said, no, we need our own group, but the caregivers need their group too. And then they can share as much as they want to, but they each have their own group and safe space to talk about and process, just like Hawa said, how important that is about what they're going through.
First of all, I wanted to say thank you, because I did benefit from the cognitive, what do you call it, behavior therapy. I was one of the first actually to go through it with a lot of when it started. And so I wanted to say thank you for that. And actually today, as I was arranging my stuff, I saw the folder that I used, and I was going through it, and I was like, no. But anyway, and what I wanted to add to that is that what I've learned is that when you have young kids and you have to break it to them that you have cancer, it's one of the most young kids or families, one of the most typical things you can go through. From a patient perspective of what I've learned and what I usually convey to breast cancer patients is that if you have a young child, communication is very important. You have to be straightforward, but you have to keep the conversation at the child's age. I'll take an example. I have a daughter who's very smart, who's beyond her years, when we talk. I know that about her. But with the cancer information, if I base my information to her on what she already knows, believe me, she's gonna carry a weight that's too heavy for her. So from my experience, what I did though, is to give her information based on her age, because even though I know, she's baby. So I go on the information that's based on her age, because I don't want her to carry the heaviness of what I'm going through. So it is important for parents to know that when you're giving that information, yes, you have to be honest, but keep it at their age level. That is very important. Don't rely on, they are so smart, they are so mature, and then you give them this information. Well, they can be all mature, but believe me, for me at least, what I've learned through the process is that they might be all this mature, but some information, when it comes from the right person they love and admire, it is very heavy. So my advice is to really keep the information at the child's age level, at their, they have, their grade, if there are sixth graders, what they're doing in their life at that time. But don't base it on their maturity. That is important, because you want to make sure they don't carry that big of a weight, where you want them to still be a child. While you're going through this, yes, they're going to be part of it, but at the same time, they have their lives that you have to protect and allow them to live without this heaviness on them. So I just wanted to add that.
It's such an important point, and I wanted to point out that it can be scary and overwhelming, and you might not know, what does that mean? What does it mean? My child's 6, what does that mean? Or my child's 12, what does that mean? The Cancer Education Center can help you decide what is the right level for your child. So again, Gonda building, lobby level, and just starting with a navigator. And we have child life specialists who help children therapeutically with play therapy to help them process what's going on. And we have pediatric psychologists as well. And I'm an adult psychologist, but I partner with my pediatric psychology colleagues. For example, sometimes when I'm seeing mom or dad and they're seeing the child at the same time, and we all work together.
And if I could add my perspective on just coping with a family member who has a diagnosis of cancer. When I was a second year medical student, my dad got diagnosed with acute myeloid leukemia, and it's a very aggressive form of blood cancer. And I remember at the time I had just learned about blood cancers in medical school and what they're like, what's the treatment, what's the prognosis, all of this information. So when I heard that he had this diagnosis, it was shocking to me at first. But then for me, coping was trying to figure out, okay, what's the next step? Okay, what's the mutation here? What's going on? Who is he going to see for treatment? But through all of that, knowing the numbers for people who have this diagnosis, that was what scared me. But at the same time, I was hopeful that maybe there is, maybe he's not in this majority here that have a poor outcome, or maybe there's a new treatment that's being developed, and then also trying to at the same time share some of this information with my family, trying to break down that information that they're getting from his physicians and his care team. But throughout all of that, I was just holding out hope that this is gonna be different than what I know. And trying to share as much information with my family without being too vague. Because sometimes it's hard to hear what you're hearing from the doctors if it comes to prognosis. Some people don't want to hear that. Okay, most people live 6 months, or most people live 5 years. What is the survival rate? All of that information is hard to digest, and you might just blank out as soon as you hear the diagnosis, and the rest of that conversation goes out the window. So a lot of it is trying to understand as much as possible, trying to hold that hope, and that's what really kept me as a family member of somebody who had cancer, going and making sure that I finish the rest of my education and be able to be there for my family as much as possible.
I just wanted to add to that. When I'm working with patients, we talk about the importance of taking time to process the emotions in balance with living your life, doing the things you enjoy. And we want that same thing for kids and family members. So it's important to have both of those, to not get caught up in the emotion and be sad and fearful all the time, to not ignore it and focus on living life, but to have that balance with both of them for everybody.
One thing I just remembered is that we all hear, one thing that we all do, actually, is that when a cancer patient, if somebody we know have cancer, of course, it comes from a really good place. We reach out to them and we say, please, if you need anything, let me know. What we forget is that those are words. But if after those words, we're not proactive in coming back to that patient and really trying to do a research on our own to say, oh, what is a new cancer patient, what do they need? And come back and say, you have a daughter, for instance. Can I just take her out for a few hours? Something like that. Because behind the word, there has to be something proactive. Some of us are, it's not because, for some of us, it's really hard to ask for help. When you haven't grew up with that, it's really hard to ask for help. And when a cancer patient actually doesn't even know what they need. And sometimes people forget this, because you are also learning. Actually, when you learn you have cancer, it's like everything is in the cloud, like everything is floating around. It's a new world for you that you are discovering. So you have this outpouring love coming from the people you know and the people that want to support you, but they don't understand that you don't even know what you need. And I wanted to give that advice to all of us here, that sometimes it's not because the cancer patient doesn't want to ask for help. Well, sometimes, yeah, they might be ashamed and they're not used to it and all that. But sometimes it's because they don't even know what they need. And they're also learning as they go. So it's really hard for them to communicate to you, this is what I need. Could you help me with this? But after the word, if we are proactive, if you know this is somebody that likes to go for a walk, just visit them, take them for a half an hour walk, for fresh air. That's support, And if you know this person likes to read books, believe me, with cancer, they will have time, in their hands while sitting in a chemo care or a radiation care. So they could be able, to enjoy those books, trying to find out, oh, what kind of book do you like? Those are supports, but we have to proactively do our own research, know if they're really close friends, what they usually enjoy, and make sure we make the journey normal for them. So that they don't feel like, because in my community, for instance, when you have cancer and you're going through this harsh treatment, the treatment that you're going through, you lose weight, we're trying to hide you. It's like, no, you have to stay home because if you go out this skinny, it's embarrassing. You know, where is the support in that? That's what happens in my culture. We try to, like, your normal things that you would do, you're like, no, you have to stay here. If people see you like this, you weren't looking like that before, you know, it's kind of embarrassing. So you're reduced to your tumor. Like your dignity, your worth, is no longer there. And you're not cancer. You happen to have cancer. You're a human being like everyone else, deserving love and care and everything that everyone deserves. Why should I erase myself just because I have cancer to make anybody feel comfortable? So I just wanted to put that advice there. Thank you.
Thank you all so much. We do have to wrap it up. I just got the word from the staff here that they need to set up for their next event, but like Dr. Ehlers said, I'm so glad that this Q&A, is as long as it was, because it means we're all ready to kind of start talking about it. And that's a really good thing. So thank you all for coming today.